Good morning and welcome to all of our global colleagues and friends from around the world. This is our third virtual global grand rounds from the American Academy of Otolaryngology Head and Neck Surgery for 2023. Today, we are very excited to have a renowned lineup of global speakers on contemporary management of salivary gland disorders, and we're going to get right to it this morning. A couple of quick introductions. So I am Mark Zafirio. I'm honored to be the coordinator for international affairs for the Academy. And just to sort of mention a word about our global grand rounds, for this particular global grand rounds, we have over 1,500 attendees registered from over 122 countries. So we're very excited about that. We are very honored that this particular global grand rounds is co-sponsored by the Asian Society of Head and Neck Oncology, ASHNO. Each one of these global grand rounds, we invite a sister society from across the globe to partner with us. And so we're very excited to have ASHNO with us today. We will have a few introductions and then we'll jump right into our panel here. But first, we'd like to hear from the president of the American Academy of Otolaryngology Head and Neck Surgery, Dr. Kathleen Yaremchuk.
Welcome. It is so exciting to be here today with all of you. I love seeing in the chat box everyone that's joining from around the world. We have over 1,500 registrants for this to learn more about salivary gland neoplasms, and it is truly inspiring to have so many committed physicians joining us to do the best for our patients wherever they live. Enjoy the proceedings and their presentations today, and thank you again for being committed.
Thank you, Dr. Yaremchuk. We also have with us today Dr. Jim Denaney, who is a global leader in otolaryngology head and neck surgery education and serves as the Executive Vice President and CEO of the American Academy of Otolaryngology Head and Neck Surgery. Dr. Denaney.
Thank you, Mark. I again would like to echo Dr. Yaremchuk's welcome and thank you all for attending, particularly the speakers. This is a fabulous group of speakers that Dr. Hao and yourself and our international leadership team have put together. The series of these over the last several years have been probably the most attended things we do internationally. I'd also like to welcome you if you're able to attend our meeting in Nashville this year. We have our first meeting that we have an international day where we have a full day committed to great international programming, and we look forward to seeing you there. And I look forward to hearing this talk today. Thank you again for all the participants.
Thank you so much, Dr. Denaney, and for all that you do for global otolaryngology head and neck surgery education. Without further ado, we have Dr. Sheng-Po Hao, who is also our moderator. But first, I want to introduce Dr. Sheng-Po Hao as the founding president and general secretary of the Asian Society of Head and Neck Oncology, ASHNO, who we are very excited to have join us today. Dr. Hao.
Yeah, thank you. We are honored on behalf of the Asian Society of Head and Neck Oncology. We are really honored to be able to co-host this webinar with the American Academy. And I just want to give you a brief introduction of the Asian Society of Head and Neck Oncology, the ASHNO. Actually, the ASHNO was initiated in July 21st in 2008 in San Francisco with the aims to promote and advance the knowledge of prevention, diagnosis, and treatment and rehabilitation of neoplasms and related diseases, such as today the salivary gland disorders of head and neck in Asia. And now ASHNO is actually a multidisciplinary society of head and neck oncology. We include people, head and neck surgeons, medical oncologists, radiation oncologists, as well as some allied science professionals. And ASHNO, as you know, the representative society of head and neck oncology Asia, we are very keen to promote our activities in the whole world. Especially, we love to have some cooperation with the American Academy. And actually, the ASHNO is honored to become an international corresponding society of American Academy since year 2012. And now, even more honored to co-host this webinar with American Academy tonight, or in the morning. Anyway, today with the American Academy. So today, could I have the next slide, please? So today, the global grand round will be the contemporary management of salivary gland disorders. And we are honored to invite some of the distinguished speakers from, Philippines, from Malaysia, from Japan, and from Thailand. They are all, member countries in the ASNO. And today, I think may I introduce the first speaker. Yeah, Jennifer Almelor-Alzaga. He is from University of Philippines. He's actually one of the a new female head and neck surgeons, the new female power in Asia. He is currently served in the University of the Philippines, Philippine General Hospital, Manila Doctor Hospital, and Makati Medical Centers. And actually, he completed two fellowship in the head and neck. So Jenny, he is going to share with us first for the night, the surgical management of benign salivary gland tumors. Jenny, please.
Okay, good morning. Thank you for this opportunity to participate in this event, and I'll be discussing about the surgical management of benign salivary gland tumors. Just an overview of the flow of our lecture. So among the benign salivary gland tumors, majority occur in your parotid gland and less commonly in the submandibular and minor salivary glands, and even rarely in your sublingual gland tumors. There's a female predilection, and children account for less than 5% of all salivary gland tumor cases. I'll be focusing on the parotid because majority occur there. And in the parotid gland, majority occur in the superficial lobe. Around 10 to 11% occur in the deep lobe, and less of them occur in the accessory lobe. So this table just shows that the majority of your benign parotid tumors are your pleomorphic adenoma and Martin's tumor. And among your benign parotid tumors, it is the pleomorphic adenoma with a malignant potential of up to 15%. Pleomorphic adenoma has a irregular border, but important to remember is that it has pseudopodia, which are finger-like projections that extend into the normal parenchyma of the parotid, such that if there is inadequate resection, you may leave this behind and cause recurrence in the parotid. Martin's tumor is a tumor of the elderly occurring on average around 60 years, and smokers have higher risk for this type of tumor. Important to remember is that 15% are multifocal, hence most commonly the offered treatment would be superficial or partial superficial parotidectomy. However, there are some select cases wherein you may propose active surveillance. This just shows the list of possible techniques that you may perform in treating parotid tumors. I will not go on discussing the biopsy or the radical or extended parotidectomy, as these are mostly for the malignant tumors. Main factors that you need to consider when choosing the appropriate technique would be one, the tumor location. Is it located in the superficial lobe or deep lobe? What is its size and histological phenotype? Those surgeons who are still new in their journey are advised to perform superficial or partial superficial parotidectomy so that you orient yourself in the anatomy and the proper dissection of the facial nerve and its branches. Since intraoperatively, if you need to switch from the conservative to the more extensive, you are able to do so. Enucleation is actually an obsolete option for your benign parotid tumors, as this entails incision on the capsule, and there is a very high recurrence rate. Among the conservative parotidectomy techniques, your extracapsular dissection has been studied for the past 15 to 20 years and has a good safety profile with a low tumor recurrence rate, provided you perform good patient selection. The difference with your partial superficial and superficial parotidectomy is that in ECD, you excise close to the tumor with a close margin of 2 to 3 millimeter normal tissue, and the main trunk is not dissected. Since this precludes the pre-identification of your facial nerve, you have to have good intraoperative facial nerve monitoring. This is ideal for tumors that are small, mobile, mainly located at the tail of the parotid. This shows the ideal candidates for extracapsular dissection, those that are small, around 2 centimeters or less, well palpable and mobile at the periphery of the parotid gland, especially at the caudal posterior area, which is your tail of the parotid, wherein you do not expect any contact to any of the cervicofacial division branches. Tumors in that location, even if they are more than 2 centimeters, may still be considered as ideal candidates. Other possible tumor locations would be those at the caudal anterior area. However, here you might expect stimulation of your marginal mandibular nerve. In these smaller tumors, you may perform a limited semicircular canal skin incision or the incision towards the hairline for better cosmesis. Okay. Now, these are possible candidates for ECD. Possible meaning if you have more experience with this technique, even if they are larger, you may try to perform ECD, provided you can switch to a more extensive surgery intraoperative. So larger tumors, 2 to 4 centimeters at the caudal area of the parotid gland, with expected possible contact to your cervicofacial division, or in the cranial area of the superficial lobe, with possible contact to the temporal branch. Even smaller tumors who are near the Stensen's duct may be possible candidates for ECD. Partial superficial parotidectomy, on the other hand, you have a wider margin of around 1 to 2 centimeters. And the difference here is that you have to identify and dissect the main trunk of the facial nerve, as well as the branches that are near the tumor. But difference with superficial is that you do not dissect the parotid tissue that is far away from the tumor. This has a better complication profile than superficial parotidectomy, but still providing good margin of resection. Tumors that are middle-sized, 3 to 4 centimeters at the caudal part with contact to the main trunk, or larger tumors still at the caudal part, but now with contact also to the cervicofacial branch, are indications for partial superficial parotidectomy. Benign parotid tumors near the main trunk at the cranial area with contact to your temporofacial division are also candidates for partial superficial parotidectomy. Okay, so with superficial parotidectomy, this entails removal of all parotid tissue lateral to the facial nerve. And the difference here is that you dissect not only the main trunk and the branches near the tumor, but all the other branches of the facial nerve. Advantage would be a standardized identification of the facial nerve. So this is a good technique to be learned by junior surgeons, and you would expect a lower recurrence rate because you remove all the parotid tissue. Larger tumors with contact to multiple branches, but no extension to the deep lobe are the main indications for this technique. Just reiterating that medium to large size tumors with contact to both the cervicofacial and the temporofacial division or multiple branches are the indication for superficial parotidectomy. But again, there should be no extension to the deep lobe. Total parotidectomy entails a removal of all parotid tissue, both medial and lateral to the facial nerve. Mostly the indication for this would be for malignant tumors, but for benign parotid tumors, if the tumor is located in the deep lobe or from the superficial lobe, there's extension to your deep lobe, then you need to perform total parotidectomy. Again, for benign surgery, tumors of the deep lobe, tumors of the superficial lobe with extension to the deep lobe are the main indications for total parotidectomy. This algorithm just reiterates what we discussed, the anatomical criteria to determine the appropriate parotidectomy technique for your benign parotid tumor. You may have other criteria influencing your decisions, such as the histopathology, the result of your intraoperative frozen section, or if this is a recurrent tumor. For example, in Marthin's tumor, since this occurs multifocally and you may have local inflammation complicating your surgery, you might need to proceed to a more extensive surgical technique. In Marthin's tumor, there is a question if you can offer active surveillance rather than outright surgery. And there are 4 scenarios where you need to perform outright surgery for Marthin's. One, if you cannot reliably diagnose Marthin's tumor because there's no concordance with your clinical data, the imaging, and your biopsy report. If there is cosmetic concerns, the tumor is large, there's ulceration, recurrent infection, or the patient is desirous for surgery. Otherwise, you may offer active surveillance, provided you can reliably diagnose Marthin's tumor. Again, active surveillance can be offered for incidental findings of Marthin's tumor, In elderly patients who may have significant comorbidities, especially they found that with the elderly, the growth of the Warthin's tumor is lower, and those without clinical complaints. So you may perform a clinical follow-up with your ultrasound every 6 months to assess the growth of the tumor. This study reviewed the available parotidectomy techniques to find out a balance between good tumor resection and less postoperative complications. So focusing on the tumor recurrence, disregarding, of course, enucleation, they found that among the 4 techniques, there was actually no significant difference in terms of tumor recurrence. Again, provided you have good patient selection. With temporary facial nerve weakness and permanent facial nerve weakness, there is a higher association with your superficial and your total parotidectomy, and least associated with the most conservative, which is your extracapsular dissection. With Face syndrome, they found it higher with superficial and total parotidectomy because of the more extensive parotid resection, more damage to the parasympathetic nerve fibers, which then aberrantly innervate your skin sweat glands. With Sialosyl, there was no difference among the 4 techniques, but with salivary fistula, it was least associated with your extracapsular dissection and total parotidectomy. Just to summarize their results, with tumor recurrence and Sialosyl, the 4 techniques did not have any difference. With transient facial nerve weakness and Face syndrome, it was least associated with extracapsular dissection. Permanent facial nerve paresis was most associated with your total parotidectomy. Just very quickly, this is our data in our hospital. My resident and I reviewed the records back to 2019, and we have approximately around 32 cases, with most of them being pleomorphic adenoma, and the most common surgery performed was superficial parotidectomy. We were also affected by the pandemic, and our numbers decreased, but now it's slowly increasing again. But still, our most common tumor was pleomorphic adenoma, and the most common surgery performed was superficial parotidectomy. So I'm ending my lecture with this quote. This means that whether you are a novice surgeon or a skilled surgeon, you have to have good preoperative evaluation in order to make the best decision for your patient. These are my resources, and thank you for your kind attention.
Well, thank you, Jenny. It's really wonderful to listen to your talk. Thank you so much. We are going to have all the question and answer. At the end after each speaker completes their presentation. So next, I'm honored to invite Professor Prepageran Narayanan from Malaya University, Malaysia. He is really an expert in endoscopic surgery, and he is going to share with us the management of salivary gland tumors in the parapharynx and the skull base. My friend,
thank you, Sheng-Po. Thank you, Sheng-Po. Thank you very much for the honor of being invited to this global rounds. So what I will do is I'll talk about endoscopic assisted transoral lesions, as well as endoscopic transnasal lesions in the skull base. And then I'll also talk about combined approaches when you have to both combine endoscopic transnasal as well as endoscopic transcervical approaches to lesions in the skull base as well. And finally, I will end with open approaches. How do we decide the approaches? It's basically dictated by the tumor. The tumor has done the majority of the dissection itself. So the pathway of least resistant, and we need to preserve normal tissues as much as possible. So let me start. What are the advantages of doing a transoral approach for a large tumor of the parapharyngeal space? So with an endoscope assisted, you have a very clear view of the area you're doing. You're able to preserve structures, you're able to identify neurovascular structures, and then but you also need to select these patients very carefully. And let me illustrate this with cases. So this is a patient who has got a lesion at the retropharyngeal space, and we do the entire surgery endoscopic assisted. What we do is we use a Boyce-David mouth gag, exactly like how we would do in a tonsillectomy, and then a colleague or an assistant holds the endoscope. Then by looking at the screen with the amplification, we are able to excise, open layer by layer until the tumor is exposed, and then we are able to excise the tumor completely, as you can see. So this is now the view after the tumor has been excised. Again, the surgery is done quite quickly, in almost less than 15 to 20 minutes. And then you are able to visualize again by using an endoscope to see very clearly and inspect the entire cavity of the retropharyngeal space. You can actually see the carotid artery that is in this area here. And then we are able to cauterize and have a good hemostasis of the entire cavity itself. And subsequently, again, you can see the carotid artery very clearly seen. Then we place Surgicel into the area, and then we suture the area with a absorbable sutures. And in this way, the patient does not need any rice tube feeding and is able to tolerate orally the next day as well. Another example of someone who's got a huge lesion, and you can see how large the lesion is in the parapharyngeal space, almost literally occluding the entire cavity itself. Again, the lesion is, you can see in both the coronal section as well, how large the lesion is. So the tumor itself is already bulging into the oral cavity. Again, the same way by using a Boyce-David tonsillar mouth gag, you can see the entire extent of the tumor. And all it takes is for us to use with an endoscope, you get a very nice amplified view. Then all we need to do is open layer by layer, and open layer by layer. There'll be a lot of pseudocapsules, pseudofascias, and we have to open layer by layer until we are able to visualize the entire gland, entire tumor itself. Then we need to dissect the tumor very gently so that we do not break into the capsule. And you can see sometimes it's bilobed, and in the lower part you tend to have much more fascias as well. That needs to be identified and dissected as well. And finally, we are able to go all the way lateral, make sure we dissect with a nice margin and cauterize the feeding vessels as we remove the tumor. So again, by doing this method with the view that we get, we are able to do these surgeries in less than half an hour because you are able to visualize the whole thing. And then we are also able, with an endoscope, to see and examine the bed of the cavity that's left behind. We are able to make sure there is no tumor left behind. And sometimes you're able to visualize the carotid artery as well. Again, stop all the bleeding, use Surgicel into the area, and then we suture with a Vicryl. And again, we do not need a rice tube feeding, and just observe the patient for 24 hours to 48 hours, and the patient can go home quite well. This is the post-op view after 2 weeks. Another example of a patient with a large tumor. You can see how large the tumor is and how it's bulging into the oral cavity itself. And again, you can see how by using a Boyce-David mouth gag, this is uvula, by the way. The entire tumor is pushed the uvula to a side, literally occluding the entire cavity. These patients require a nasal intubation. And again, the surgical steps are exactly the same. By using an endoscope, the entire view is amplified, and then we open layer by layer until we are able to visualize the tumor. So in this case now, we have come and dissect the tumor from the side, and also dissect the tumor from this angle. And sometimes you can just put a finger inside and the whole tumor comes out quite nicely as well. And subsequently, what we do is we pack that area, and you can see the amount of redundant tissue that is there. And once we remove the ribbon gauze, we are able to inspect the entire cavity, and then we cauterize all the bleeding vessels, and then we close in layers as well. And this is how the entire surgery is done. Again, these surgeries are done quite quickly, and these are all pleomorphic adenomas, and within 45 minutes, the entire surgery can be done quite easily as well. Let's look at malignancies. Let's look at hybrid surgery. So this was a difficult surgery because if you look at the lesion, you have a lesion that is coming all the way from the parapharyngeal space into the cavernous sinus, into the clival, into the Meckel's cave. So this is going to be an absolute nightmare. We will not be able to remove the entire lesion in one sitting itself. So what we did was, we did the surgery in 2 sittings. So first of all, we did an endoscopic transnasal. We are able to identify the tumor that is coming into the nasopharynx from above of the Meckel's cave area as well. Then once we open up the sphenoid sinus, we are now into the sphenoid sinus itself. We are able to identify the lesion in the Meckel's cave region and in the clivus itself here. So now we are going to see and remove the tumor. That's the optical keratical recess. That's the clivus. That is the tumor going into the Meckel's cave, as we can see, and then in the cavernous sinus. That's the area going into the clivus. So what we need to do now is we're going to resect the tumor from the clivus by using instruments. Sometimes you're not able to remove the whole thing in total. It requires a piecemeal resection because of the way the tumor is. There's a tumor in the clivus and it's being dissected layer by layer. The next step would be to remove the tumor from the Meckel's cave. That's a tumor that's going into the cavernous sinus in the Meckel's cave. So what we need to do, we need to remove, debulk the center of the tumor, and then we are able to dissect the lesion quite nicely. So in cases like this, we will not be able to remove the whole thing completely. So the basic principle will be to debulk the center of the tumor, and subsequently the capsules can be, as you can see, now we are able to identify the capsules in the Meckel cave and dissect the tumor out with the capsule from the Meckel's cave itself. And you are able to see the extended, the dilated Meckel cave with a paraclival cavity that is seen. And this is the final view of the surgery. And again, you can see very nicely how the tumor has been removed from the clivus. Here, that's the optical keratical recess, that's the cavernous sinus, and that's the dura of the Meckel's cave in the middle cranial fossa that has been removed. That is the part in the nasopharynx itself. But now we have to remove in the parapharyngeal space. For that, we open up the neck, identify the carotid artery, the hypoglossal, retract the carotid artery away with the hypoglossal, and identify the tumor at the upper part of the parapharyngeal space. And here you can see how the carotid artery has been dissected away and the tumor is visualized. And subsequently after this, the tumor is being removed. And then we need to follow the tumor through the trans-cervical approach. So by using an endoscope and going through the approach in the neck, we are able now to follow the tumor as it goes between the pterygoid muscle. So that's the tumor. And then by using an endoscope, we will never be able to reach this with an open method unless you do a maxillary swing. But what we do now is we are actually going between the pterygoid muscle. This is the tumor that is going into the parapharyngeal space. We are able to follow the tumor all the way up until we are able to identify the dura of the middle cranial fossa and the Meckel's cave. There's the dura coming into view. And with this, we know that we've been able to remove as much tumor as possible through the cervical approach into the parapharyngeal space. So that came back as a low-grade myoepithelial malignancy, and that has been now gone to the oncological lesion. How do we approach large lesions? So this is a patient who's got a large lesion, and in this case, what we did was we did an open surgery, open trans-cervical surgery. Remove the lesion from the neck, as far as you can see here. And there's a tumor that's been dissected out. And then the tumor that has been removed from the neck itself. And this is the cavity that we have. And this is how large the tumor is from the parapharyngeal space. And then we are able to visualize by putting in an endoscope into the cavity itself to inspect, make sure the tumors are all done. The pterygoid muscles, that's the carotid artery in the skull base. And then we are able to visualize to make sure that all the tumors has been completely removed as well. This is how the patient looks like in day one after the surgery has been removed, after the tumor has been removed. So this is the last case I'm going to show you where we had to remove the tumor in an open way. You can see how large the tumor is. And again, you can see the tumor is actually involving the skull base extradural, pushing up the dura of the cerebellum. What makes it difficult is that it's actually extending into the prevertebral space into the spine region as well. And again, you can see how it's extending anteriorly and extending posteriorly as well. The FNAC that we did just showed as inconclusive. So we had to excise the whole lesion. This is the neck incision. This is the sternocleidomastoid that has been thinned out. We open up the sternocleidomastoid in layers. The tumor has been dissected out. And again, you can see how the tumor is very large. And it's very important for us to remember that there will be very significant bleeding. And that's the kind of bleeding that you can expect from the prevertebral space. The blood just flows out simply because the tumor has been compressing on the prevertebral space. And then once the tumor comes out, that's the dura. That's the dura of the postcranial fossa, the dura of the cerebrum, and we are cauterizing the bleeding, as you can see. And this is the tumor itself, and that's the amount of blood that you tend to lose during extensive surgeries like this, because it just oozes, it's not shooters. You tend to lose quite a substantial amount of blood. This came back as a fibrous tumor from a salivary gland, one of these very unusual tumors. Post-op, and he's quite well after surgery. So again, in conclusion, the definition of success has to be defined by the patient. It's not enough for us to say, oh, we've removed everything, but the patient has got a morbidity of cranial nerve palsies, of not being able to eat or aspiration. And we have to individualize each approach to individual cases as well. Life is already complicated in our parts of the world. Let's keep work and surgery simple. Again, thank you very much for your kind attention.
Well, thank you, Professor Prepageran. It's really a very nice talk, but I guess there are some questions, especially to the selection of endoscopic approaches versus the open approaches. We can do that at the end of the audio presentation, after finishing the presentation. And the next speaker will be talk on the shallow endoscopy by Professor Takeshi Matsunobu from Japan. He is an associate professor in the Department of Otolaryngology and the neck surgery at Nippon Medical School in Tokyo. He is really the expert in shallow endoscopy, in all kinds of endoscopic approaches to the neck tumors. He served as the chairman of shallow endoscopic surgery committee in the Japan Society of Stomatopharmacology. Yeah, so Professor Matsunobu, please.
Well, thank you very much for giving me an opportunity to talk in the virtual global grand rounds. Today, I'm talking about the management of obstructive salivary disorders, and especially focusing on shallow endoscopy. Well, I have no COI to disclose. Well, there are three major salivary glands, and my presentation is mainly related to the duct problems of salivary gland, Walton duct, and Stensen duct. The most common obstructive source is sialolithiasis. Strictures and stenosis of the duct can lead to similar intermittent periprandial symptoms. Inflammation and fibrosis from radiation and autoimmune process can damage both the salivary parenchyma and the duct. In addition to salivary swelling and sialagnitis, these patients typically suffer from xerostomia. Here I introduce the shallow endoscopy. Shallow endoscopy is a minimally invasive approach for the treatment of obstructive and inflammatory salivary gland disorders. Scopy has resulted in increased interest in gland-sparing treatment by both surgeons and patients. Adoption of shallow endoscopy continues to grow, and its application continues to broaden. If the patient has no symptom observation, if the patient has pain or swelling of glands, recurrence of inflammation, we have to select surgical approach. Traditionally, stone located in intraduct, we choose transoral approach. Higher malaria, transoral approach, or in most cases, removal of gland. The stone located in intragland, we usually remove gland. The concept is gland preserving surgery using shallow endoscopy. Real treatment options essentially limited to observation with symptomatic management or gland incision. About under treatment, recurrent symptoms from small stone can impact QOL. About over treatment, nobody would ever remove kidney to treat a kidney stone. We would like to avoid steroidectomy. Geneva in Switzerland group, or Arangen in Germany group, or Israel group have developed steroid endoscope from the end of 19th century. In Japan, we started to use steroid endoscope in 2007. Steroid endoscopy can be used for any source of salivary swelling. It can be diagnostic or therapeutic. Indication include psoriasis or other obstructive lesion, strictures or stenosis, kinks, mucus plugging, radiation-induced steroiditis, juvenile recurrence parotitis, salivary duct cysts, trauma, acute steroiditis, or technical limitations. Steroid endoscope is rigid, cannot navigate branches, and scope is fragile. Scopes and baskets can break. Lithotripsy, slow and tedious and can cause thermal ductal damage. About anatomic limitations, mandibular tori are rarely problematic. And inward angle molars can be problematic like this. Or incisor teeth can be problematic for submandibular gland ductal access. Complications include ductal perforation, ductal abrasion, retained stone, stricture, recurrent stone, radula, equipment damage. I will introduce our experience of steroid endoscopy. We have published the outcomes of the scope surgery. We are using Marshall type all-in-one steroid endoscope. There are another type of scope. This is from Arangen in Germany. We don't have this. About operative instruments, this is grasping forceps, stone extractor wire basket. This is a micro bulb diameter of 0.38 millimeters. This is mainly used for stenosis. Introduction of the steroid endoscope is very important. Very gentle duration of opening of the duct is necessary. We usually use conic dilator and gloves. Normal view of the lumen of the Wharton's duct. Pink colored lumen is observed here. We can observe main duct, second and third branches of Wharton's duct. I will show you some cases. Case 1, ductal stone of submandibular gland. The scope was introduced into the right Wharton's duct and removed with the wire basket. This is easy case. Second case, endoscopic removal of parotid gland ductal stone with holmium YAG laser. The steroid endoscope was introduced through the opening of the stencil duct and checked the stone. The point at which the stone located was illuminated. The stone was fragmented by holmium YAG laser. and removed by wire basket. Case 3 is a combined approach against submandibular gland in the hiatum area, namely endoscopic assisted approach. First, we observed and illuminated the stone using endoscope and make incision floor of mouth at which the stone located. Usually, we place the stent and keep it for a week. This is flowchart for submandibular gland in our department. And the procedure was selected according to the stone size, shape, and location of stone. This is a flowchart for the parotid gland. The procedure was selected according to the size, shape, location of the stone as well. About the complications, there are few complications, but we perform a combined approach. We should pay attention to the lingual nerve because it can appear in the surgical field of most cases. I'm moving on the ductal stenosis. It's second most common cause of recurrent salivary obstruction. Causes include idiopathic, iatrogenic, stones, autoimmune disease, radioactive iodine therapy, juvenile recurrent parotitis. Evaluation of the stenosis is performed by ultrasound, scintigraphy, and shell MRI. The classification of the stenosis is shown. This is proposed by International Shell Endoscopy Society. This is classified from S0 to S4. And the management of stenosis, the surgical duration and the endoscopy include dilators, guide wire, hydraulic irrigation, mechanical dilation with shell endoscope from 1.1 millimeter to 1.6 millimeter, and balloon steroid irrigation. Let me introduce some cases. This case is 66 years old male, left parotid gland swelling. He has been suffered from systemic sclerosis. Their endoscope was introduced into the left stenosis duct. The lumen of the duct was white and a lot of debris was found. Washout debris in the stenosis duct was performed, followed by hydraulic irrigation and steroid irrigation, introducing steroids. Next cases was 35 years old female with web-like stenosis of stenosis duct. This is a fusion image of CT and CR and MRI. The web-like stenosis was successfully dilated using microbar under the CR endoscope. It has been shown that CR endoscopy is effective for duct problem in Sjögren syndrome. The adoption of CR endoscopy continues to grow and its application continues to broaden. Conclusion, CR endoscopy is minimally invasive approach for the treatment of obstructive and inflammatory salivary gland disorders. Thank you very much for your attention.
Well, thank you, Professor Matsunobu, wonderful lecture again. And thank you so much. We'll come to the question and answer at the end. So the last speaker in this webinar will be Professor Patravoot Vatanasapt from Thailand. He's a professor in the Khon University, and he's also the current president of the Thailand Head and Neck Society, and he is the current president-elect of the Asian Society of Head and Neck Oncology. That means he's going to host the next national meeting in Bangkok, in November, I guess, this year. So, Professor Patravoot, please.
Okay, thank you, Peter, for your kind introduction. And it is my great honor to join with the virtual global grand rounds from the American Academy of Otolaryngology, head and neck surgery, and joined with Ashno. So today I'm going to talk about focus on the extent of the surgery for the malignant salivary gland tumors, which fortunately all the previous speakers, especially Jenny, has already mentioned about the surgical procedure, so it makes my talk quite easy. Yeah, I think most of you have experienced this kind of the two ends of the spectrum of the salivary gland cancers. And I would say this is kind of the paradox in the surgical management in terms of the surgical technique and the decision making. In some certain circumstance, you find the disease quite easy, located in the superficial lobe, but it is very difficult to make decision whether you're gonna go on with the deep lobe. But when you see the case just like on the right side, when the tumor is far deep, involve both superficial and deep lobe, and the facial nerve function has already gone, even though, you know, with this surgical technique might be a little challenging, but the decision making is quite straightforward. So today we're gonna focus on the decision making rather than the surgical technique itself. For malignant salivary gland tumor, it's relatively rare comparing to the remaining types of the head and neck cancer. It's about 3 to 11%. And if you look at the distribution in this heat map on your left side is the incidence of malignant salivary gland tumor. And on the right side, you can see the mortality. And you can see that even in the country with a very high incidence of malignant salivary gland tumors, but the mortality it's still low, whereas some part of the world with not that high incidence, but mortality is relatively high. So this indicates that this kind of tumor still have ample room for improvement in most places, and still is quite convincing in promising in terms of survival. So I think this is an important role for the surgeons to know how we can go about. And when talking about the types of the cancer, as we all know, that the majority, about 1/4, is mucoepidermoid cancer, followed by adenoid cystic carcinoma and other types of cancer. And this is from the 5 regions in the global. Actually, majority of malignant salivary gland tumors confined in the minor glands, about 40%. 1/4 in the parotid, but because it's quite challenging for the surgery in the parotid gland, I would focus on this type. And this is the data from Khon University where I work, and you can see that in every year, it's like in the 20 years, you can see that the incidence of mucoepidermoid is increasing. I know cystic carcinoma is gradually increasing, but interestingly, adenocarcinoma just dropped here as well as the acidic cell CA. It's just hard to say that whether it is the real drop of the incidence, but it is because of the changing in the definition of the pathology of the salivary gland, which is quite challenging, and this is also important for the management of the salivary gland tumor. And this is the survival. You can see that different types of the cancer have a different behavior. So it's very important that we have to know, especially preoperatively, for making the right decision. And you can see here that the early stage perform far better than the advanced stage, and the role of post-op radiation is not that much improving of the survival. So generally, The malignant salivary gland tumor, we approach just similar to the remaining part of the head and neck cancer. But for the imaging, besides using CT, MRI, ultrasound, we also need to know preoperatively about the pathology, either with the fine needle aspiration biopsy, and nowadays more and more an attempt to apply with the core needle biopsy to have the more accurate diagnosis for the accurate decision making. For in the diagnosis, we need to know the site, the extent, and also the cell types. And for treatment of malignant salivary gland tumors, rely more on the surgery, radiation in some cases that the surgery cannot do well or with the unfavorable prognostic factors, and the little role with the systemic therapy, but still, which I'm not cover about in this talk. So why surgery for malignant salivary gland tumor is challenging? That's because the behavior is quite different from the remaining part of the head and neck cancer. The disease confined in the gland, and also it's challenging because the lymph node, we also found the intraparotid lymph node, which is very important in making decision for the extent of the surgery. The histology is also complex because it's not only in the epithelium, but through the dark, the mesenchymal tissue with the histopathology, which is more diverse than the head and neck, which majority are squamous cell. The response to radiotherapy is more resistant than the squamous cell, which make the surgery is very important. But again, the surgical challenge is still there because the proximity to the nerve and also the determining of the surgical margin, rather than instead of the mature margin, just like the surface of the mucosal margin is squamous cell, is more approached as a compartmental. So the other challenge is that supported evidence is quite limited because the incidence is not as high. So still need some of the expert opinion. But still, if you look at the evidence here, you can see that the pattern of treatment failure for the salivary gland cancer, the factors that indicate or determines the recurrence here is the perineural invasion, the margins, and also the histology gradings, which is very important for making decision in terms of the surgery. And what important for the significantly related to the distance recurrence is also the positive margin. So what is the positive margin and how we can get the adequate margin is the story that we're gonna talk about. So in terms of decision making for parodonticectomy, we start thinking whether is it operable or not. So we have to look at the extent of disease, whether this presence of distant metastasis, is there any severe comorbidity, and for making next we have to think the extent of the surgery. So again, what is the extent of the disease in terms of parotid? We have to look at the deep lobe of the parotid. Is there any disease right there? The pathological grading, is it high or low? And also the presence of the intraparotid lymph node or the risk of the intraparotid lymph node. And what makes the surgery more challenging is the preservation of the facial nerve, which we need to evaluate the preoperative function of the nerve and also intraoperatively the facial nerve involvement. And for the neck disease, it's quite straightforward depending on the presence of the neck, the size of the primary tumor, and also the grading of the pathology. So in terms of histopathology, as we know that histology grading is the independent predictor for the behavior. So we need to know whether it is low aggression or high aggression. However, in the recent recommendation from the WHO is that most salivary gland carcinoma have an intrinsic biologic behavior. So in the future, it is likely that universal grading scheme are not recommended. So we may need to, tailor-made according to the cell type. And not to mention about the high-grade transformation, which can make the decision even more complicated. The second thing is the intraparotid lymph node metastasis, which can be found, as you can see here, the lymph node 70 to 90% presents in the superficial lobe, but still there is a chance that the lymph node positive can be in the deep lobe, about 20%. And you can see overall the pool prevalence is from 7 to 70% depending on the risk, but generally is about 1/4. And if the patient has the intraparotid node positive, it's increased the risk of death by double. So it is very important that we need to make decision based on the presence of the lymph node. So what is the extent of the parotid? What need to take into account is the T staging and also the grade. If it is a T1, T2 and low grade, there is a low risk of intraparotid lymph node, which and still high survival, even a close margin. It means that if the tumor even close to the nerve, about 1 millimeter is still adequate to remove just only the superficial. So superficial parotidectomy is still sufficient, and even further partial if there is no risk of the deep lobe involvement and the lower half resection is still possible. But for the high stage, like 3 or 4, or the high grade, there's a high risk of intraparotid lymph node metastasis. So at least superficial parotidectomy is required, or otherwise total is needed if the risk of the deep lobe involvement or the deep lobe lymph nodes is likely. And again, for the facial nerve preservation, we need to see if the intact preoperative facial nerve or intraoperative dissection plane is possible. So close margin can be allowed in the dissection. So in terms of the margin, is less approached differently from the mucosal disease. So preservation of the function, the facial nerve, is mandate. But if the preoperative facial nerve, if impairment or the grossly involved by the tumor, so this a significant factor for the recurrence. So then the resection of the involved nerve should be done with the immediate microsurgical repair. So one of the questions is that whether we should remove the deep lobe, which actually rather called deep portion because it's not the real separate lobe from the superficial. So what makes the rationale for the removal is that if the tumor involve the deep lobe, or there is evidence of metastasis to the deep lobe or the intraoperative lymph node in the parotid, or direct extension of the tumor into the deep lobe, certainly we have to remove the total parotid involving the deep lobe. But there is still a chance if we may preserve with the deep lobe if there is no evidence of the lymph node is detected, or removing the deep lobe, if the deep lobe can be managed with the post-operative radiation, or removing the deep lobe can increase the risk of the facial nerve paralysis. So, or the more tissue loss with the deep lobe can make the extreme depression or cosmetic deformity, or unable to adequately remove as an en bloc. It is also optional to whether we need to preserve of the deep lobe. So the key challenges for extent or determining of the extent of the surgery for the parotid, firstly is the inaccurate preoperative diagnosis, because we rely more on the imaging and also fine needle aspiration biopsy. So in preoperatively, we may consider of the core needle biopsy in selected case that may help in making decision for the extent of the surgery. And also in the intraoperative, we can consider applying the frozen section to see what is the real extent, especially for the peritoneal invasion, which is strongly related to the prognosis of the disease. And for the facial nerve function, certainly preoperatively, we need to clinical evaluate and document. And in the intraoperatively, I think nowadays we use more of the intraoperative nerve monitoring, not to identify, but to confirm that we still keep in the plane with the preservation of the nerve. And again, patient preference is very important. So we should make a clear discussion, and it contributes to the making decision. So in conclusion, extent of the surgery determined by extent of the tumor, the histology grading, the facial nerve function, and also the presence of the neck disease. And an accurate histology diagnosis preoperatively can facilitate a clear decision for surgery treatment, which is currently a challenge. I think in the future, more and more involved in the accurate diagnosis preoperatively will take an important role in making decision, or even the staging in the future will be important in this sense. And adequate communication and discussion with the patients is mandatory for decision making. I think because time is quite limited, I believe that still more to learn. And I would like to welcome you to come to the national conference. We very fortunate to have the world-renowned speakers to organize the IFNOS symposium on the salivary gland cancer from the surgery perspective, the radiation oncology, the radiology, and also medical oncologists to see the role of the systemic treatment. So, and there's still more and more international faculties from around the world to join. So please join us in the ASTO conference from 27 to 29 in November in Bangkok. So you can scan the QR code here to join right now. The end of the early bird registry is approaching. So hope to see you all. Thank you very much.
Well, thank you, Professor Patravoot. Really wonderful lecture, excellent as usual. And I guess there are some questions in the board. So maybe let's ask some of the questions. I just summarized. I think some of the question was just focus on the preoperative biopsy. It is indicated. I think that the question was from Ita from Philippine. And so the question is, the preoperative biopsy is indicated, and what kind of tumor or what kind of which salivary glands you will consider do a preoperative biopsy, either a cytology, fine needle cytology, or a cutting biopsy. So maybe let's start from Professor Prepageran, because it seems to me you don't do a preoperative biopsy in endoscopic, in Scarface case or in parapharynx case.
So I guess that's a very good question. So basically, if the lesion is in the parotid itself, it's more lateral, then an FNEC is very straightforward. It's mandatory. But if your lesions are in the parapharyngeal space or the skull base itself, in the parapharyngeal space, we will just look at the MRI scan. You will usually are able to know whether it's benign or not. The last thing you want to do is to poke a needle into a parapharyngeal tumor that is bulging into the oral cavity and have edema or bleeding and cause stridor. That doesn't make sense. So what we always do is, if it's a large tumor in the parapharyngeal space or going to infratemporal fossa, if we know it's clearly benign based on the MRI scans, it's not vascular, and we will just go in straight for an excision biopsy because we can make out whether it's benign or not. Let's talk about lesions that we are not sure whether it's benign or malignant. If we are able to approach this lesion quite easily, either by an ultrasound guided or the CT guided, then we will do the biopsies. But if your lesions are in the cavernous sinus, in the Meckel's cave, the only way to get a biopsy there in skull base is actually to go in to operate. So So it depends on the surgeon's how comfortable the surgeon is. So whenever we have cases like this, we will actually go in and tell the patient we have to go in. There is no point us going in, taking a biopsy, and then going in again for a surgery, because that doesn't make sense at all. There's also confinements of GA time and so on. So we will say that we will go in and remove as much as we can, and only stop if it's touching the nerve, the vessels, and so on. So it's a judgment call, and I think there is no right or wrong answer. It depends on the expertise, the experience you have, and the environment that you have. But this is exclusive for parapharyngeal and skull base. Those from the parotid submandibular gland is very straightforward. It's FNAC before surgery. I hope that answers the question.
Well, thank you, Papa, and thank you. And Max, Jenny, will you do finding the aspiration cytology if you decide to do the extracapsular dissection for a small, parotid gland tumor superficial lobe?
Sorry, Professor.
Yeah, Jenny, will you do a finding the aspiration cytology in a small tumor, let's say less than 2 centimeters in the superficial lobe, and you desire for an extracapsular dissection? Will you do a finding the aspiration cytology for that?
Well, ideally, yes, I would always perform fine needle aspiration biopsy for these tumors if it is available, so that I can be more guided with the surgery. Because sometimes, of course, although the fine needle aspiration biopsy is highly sensitive and accurate, sometimes there are still cases that there might be problem with the histopathology report. So, but if it's available, I would still perform the fine needle aspiration biopsy.
Well, thank you, Jenny. And Patravoot, look at your slide. You say you only do fine needle aspiration cytology in some selected cases. So what's your selection criteria?
Yeah, well, actually, for the fine needle aspiration biopsy, I do it routinely. But for the core needle biopsy, which we need the bigger the needles and to get the accurate diagnosis, that can be in selected case. So I normally start with the fine needle aspiration, but if the fine needle aspiration did not help, but we really need the histopathology for making decision, especially when we there is an indication of being the malignant tumor. I tend to do that, and the other the biopsy that really need is that the far advanced stage of the cancer, which in fact biopsy didn't make any change in terms of the disease prognosis, but it's very helpful in terms of making decision whether it is really the surgical case or it is really radiation responsive. But again, after you do the biopsy, either with the core needle or other technique, it is very important that the treatment should be very close to the day of your biopsy.
Thank you. And so the next question will be focusing on the frozen section or not, or the margin status, because it seems to me, Prepageran, you seldom send frozen section, or you seldom to check the surgical margin, or your margin is by clinical examination only. Am I right?
You can't get margins when you do skull base. Your margins are brain, cavernous sinus. You can't be sending frozen sections from skull base and brain and dura. So endoscopic skull base is you cannot do an oncological surgery. You cannot have a 2 centimeter margin when your margins are cavernous sinus and brain. So yes, it is more or less clinical, and with endoscopic, the visualization, the magnification is amazing.
Yeah,
so
and
it's a completely
let me ask you, because it seems to me you remove the tumor always like neurosurgical way, because you remove the tumor piece by piece to compress the bulk, the tumor, and then remove the peripheral of the tumor, and then take the surgical margin. So is the surgical margin not really affect your decision to especially in some highly malignant skull-based tumor?
There is no other way.
Really affect the survival.
When you do we're talking about endoscopic cases where it's involving the skull base, the dura, and so on. So to have a classical the oncological resection with a margin, this is virtually impossible here. So the concept is the same concept as neurosurgical, which is a gross tumor resection or GTR. So the idea is to remove as much tumor as possible, preserving structures as much as possible. And you cannot have a 1 centimeter, 2 centimeter margins when you're dealing with brain, cavernous sinus, and so on. So the mindset is completely different than a common head and neck surgery.
Yeah, so thank you. And Patravoot, you have a very clear demonstration of how you would decide the margin and how you would manage the facial nerve. Would you comment on, the surgical margin in the major salivary glands, parotid gland, submammary glands? Yeah.
Yes, thank you for this question. I think the way we approach with the margin is quite different from the majority of the head and neck cancer, just like the paper mentioned. Even though some literature try to mention about like 1.5 centimeter, 2 centimeter of the tissue, but in practice, it's not that practical, and especially within the gland when there is a facial nerve line between the gland, and then if you have to measure around and then you take out the facial nerve, which doesn't make sense. And I think you all didn't approach this way. So generally, we approach as a compartment rather than the measure of the margin. And again, there is the evidence to show that, especially for the low grade, is that even the 1 millimeter of the margin is adequate. It doesn't make any difference from the broader margin in terms of survival, in terms of the recurrence. So it is still likely that we stay close. And then for instance, if the tumor confined in superficial lobe and there is no evidence of the deep lobe involvement, no intraparotid node involvement, no neck metastasis, I can do superficial with confidence. Yeah, this is what my thought.
And to carry on some of the questions asked by the audience, by the participants, in regard to the extent of the lymph node dissection, would you routinely do lymph node sampling, for example, the subdigastric nodes for parotid gland cancer, or what kind of neck dissection you would suggest for for a parotid gland cancer?
Yes, it depends on the presence of the lymph node in the neck. If there is a lymph node in the neck, certainly we can go with the comprehensive. But if there is a chance of the lymph node that's high risk, for instance, the tumor stage is like T3, T4, or the high grade tumor, we go for the selective neck dissection. So the level that really needed to remove is through 2, 3, and 4. And the remaining is depends on if there is a lymph node positive, or you find the lymph node in the certain level, you go step further, the other next level, and that would be adequate for in terms of elective neck dissection. This is my approach.
Yeah, Jenny, will you do something different?
No, I agree with Dr. Patravoot that if you, of course, have an N-positive neck, then there's no question you proceed with your neck dissection. But if there is high tumor volume for larger tumors, as mentioned, T3, T4, or high-grade tumors, and that's when you need to perform with your neck dissection.
And how about you, Professor Prepageran?
Yes, same answer.
Yeah, thank you. And so I think there are some questions in regard to Takeshi, Professor. May I ask you, will you do diagnostic shallow endoscopy?
I'm sorry.
Diagnostic shallow endoscopy. Would you do that? Diagnostic just for diagnosis, will you do that, or you always combine the diagnostic and therapeutic together?
Thank you. In Japan, the insurance doesn't cover the diagnostic endoscopy, so we do the therapeutic only.
You do therapeutic only. Yes. And how would you how will you tell your patient if you are going to do a dilatation, a balloon, CR endoscopy to dilate the duct just only because of the stricture, or you are going to remove the stone? Because in my experience, it's very difficult to tell the patient 100%. It's only stenosis or you got a stone in your duct.
Actually, I try to, but I do CT scan all the patients, sensorized scan, and if I don't find stone in sensorized CT, I don't think that stone doesn't locate there. So I tell patients, but the stenosis patient, sorry. Usually I tell a patient of stenosis, I don't promise I can delete 100%. I'm trying to irrigate and make brushing all the debris, and I try to mechanical dilation and put steroids. It is said that steroids and mechanical dilatation and hydraulic dilation is effective. So I just try. I tell the patient just try and see. Sorry, I cannot promise, but yeah, I don't do the statistics, but it seems to work. I sorry. Stenosis and stricture is very difficult to see.
Yeah, thank you so much. And also a question from Ida Lim from Philippines. She asks about is there any conservative ways before the CR endoscopic procedures for salivary duct obstruction? So is there any medical conservative management for, before you go in and do the CR endoscopy? Conservative procedure and without surgery before you go in, is there any conservative ways, medical therapy or something, a massage or something?
I decide to do surgery. I talk to patients if the symptoms is is very bad for QOL or work. So if the patient who want to receive the surgery, I do the I recommend to receive surgery. I don't do usually if the patient want to didn't have symptoms, I just stay the stone.
Yeah, so that you don't do CR endoscopy or some treatment for the so-called silent stone. Am I right? You don't do CR endoscopy to remove the tumor for silent stone.
If the patient have no symptoms, I will
not do. Yeah, thank you. It's a very good philosophy. Yeah, and I guess there are some. I think probably we could have another one or two questions. One of the questions would be does histology type inform the decision to preserve the facial nerve during surgical treatment of parotid malignancies? I guess this is for Professor Patravoot.
Well, as I mentioned in my talk, that the preservation of the facial nerve depends on the function of the facial nerve preoperatively, and secondly, the involvement of the facial nerve within the operative field. So if the facial nerve is preserved preoperatively and there is no evidence of the tumor involved in the facial nerve, we certainly do the great attempt to preserve the facial nerve, no matter the type of the tumor. Yeah, unless it is unlikely that we can preserve the nerve in a very aggressive type, for instance, like salivary duct carcinoma. This is very, very aggressive, and the tumor encased with the nerve. But again, you need to really, discuss with the patient because the complication is quite obvious. Thank you.
And I think, one of the participants asked the 4 cases with very extensive malignancies with skull-based involvement. Probably it could be better to have a diagnosis before you do a different surgical treatment or different, therapeutic procedures. And I think Professor Zafario actually responded, it really depends on the pathology. Some sinonasal malignancies, undifferentiated carcinoma are typically treated with neoadjuvant chemotherapy or combined chemo radiation therapy. So, Mark, you want to comment on this, the preoperative biopsy to decide the different treatment strategy for sinonasal malignancies or skull-based. Mark, you want to comment on this?
Well, thank you, Dr. Hao. I do think that when possible, as was sort of mentioned earlier by Dr. Narayanan, I mean, it is not always possible to get a preoperative FNA for these skull-based tumors, but when possible, it does help because there are cases where, for instance, if you have a sinonasal undifferentiated carcinoma, so-called SNUC, those patients you would typically want to treat with neoadjuvant chemotherapy or neoadjuvant chemoradiation therapy. So there are particular aggressive histologies that there are now clinical trials that have been performed and are being studied, looking at sort of neoadjuvant chemotherapy and chemoradiation therapy approaches.
Well, thank you. I guess we probably answer all the questions from the participants. I really thank you all the presenters to give you a wonderful talk, and it has been a wonderful discussion, and and even this is online, but I really learned a lot. So back to you, Professor Zafario. The time is yours. I think we still have about 8 minutes to go.
Yeah, thank you so much, Dr. Hao. I wanted to first, I didn't have the opportunity to properly introduce you since we went to straight into the ASHNO discussion and straight into the speaker introductions, but I want to just thank you for your global leadership. Obviously, you've served as the International Advisory Board Chair for the American Academy of Otolaryngology Head and Neck Surgery this year. You're also been a professor and department chair for a long time at Shin Kong-Woo Hosu Memorial Hospital and Fujian Catholic University, and have been, as has been mentioned, the founder and president, first president of ASHNO. And so really thank you for your global leadership of otolaryngology head and neck surgery, and for bringing together not only the Asian region, but all of us throughout the world in global otolaryngology head and neck surgery. So we thank you for moderating this panel, and we're so pleased to have such a great panel today. We had world-class speakers from the Philippines, Malaysia, Japan, Thailand. Really, it was such a pleasure to hear from expert lectures from all over the world, and really enjoyed the expertise and also the videos. So Just in the last 2 minutes, to mention to everybody, our next global grand rounds is November 11th, 2023, and that will be in concert with the Confederation of European Otorhinolaryngology. So we're very happy to have them on board for this global grand rounds, and it will be endoscopic ear surgery. So that's always a very hot topic. And so look forward to getting an email with the registration link for the next global grand rounds. Please put it on your calendar, same time, 9 a.m. to 10:30 a.m. Eastern, endoscopic ear surgery, November 11th, 2023. Also to mention, this was already mentioned, so be very brief. We have our annual meeting, the American Academy of Otolaryngology and Neck Surgery in Nashville, which is called Music City, which will be September, October of 2023. We will have somewhere over 7,000 attendees from 80 different countries. So we're very excited about this conference. There will be particularly some international events. There will be karaoke, an international reception on the Monday of the meeting with karaoke. As well as an international symposium, and actually a whole room dedicated to international panels and speakers. So we're very excited to collaborate with our international colleagues for this meeting. And you can register for the meeting online. If you, we do have membership discounts, American Academy of Otolaryngology Head and Neck Surgery membership discounts, depending on the WHO class of your country. There are some discounted rates for lower and lower middle income countries. And if you sign up to be a member of the Academy, you can often save money because the registration for the meeting goes way down. So you can find all this information online. And with that, just to remind you all, the attendee certificate and session recording and member discount information will all be emailed to you next week. Be on the lookout for that, as well as the registration for the November Global Grand Round. So thank you to Dr. Sheng-Po Hao and all of our colleagues from the Asian continent and across the globe, all of our colleagues at ASHNO, for an amazing grand rounds, global grand rounds today. We all learned a lot, and you can see from the comments in the chat all of the praise you're getting from all of our guests and colleagues and professors across the world. So thank you very much. So from the American Academy of Otolaryngology, thank you, and good morning, good night, wherever you are in the world.
Well, thank you on behalf of the Asian Society of Head and Neck Oncology. We really cherish the opportunity to have this, wonderful meeting with webinar with American Academy, and thank you for the opportunity. We will look forward to further cooperation in the near future. Thank you, Mark. Thank you.